A very good morning. This is 7th May 2022 and this is Dr. Manish Mahajan, your neurologist from Gurgaon. So continuing with multiple sclerosis awareness and its bytes. I would like to continue today with the disease modifying therapies. Now, to correct this and to make it more specific, I would say that when we talk about disease modifying therapies, it is disease specific disease modifying therapies. That is, it is MS specific disease modifying therapies. What are disease modifying therapies? Now, as till now we have understood that multiple sclerosis is an immune mediated inflammation. So it comes in attacks most commonly in the most common form RRMS. So the purpose of treatment and an important pillar out of the three which we discussed in the overview, that one of the treatments is the treatment of the relapse obviously, and the other one is the disease modifying therapy and the symptomatic. Now this is an important pillar. Why? Because see, the basic purpose of treatment is not only the treatment of the symptoms which have already happened, but to prevent further relapses as well as to control and to prevent the disability happening not only from this relapses but also independent of these relapses, which I mentioned on that day as progression independent of relapse activity, that is PIRA. So how do we do that? So the purpose in the initial phase when the immune mediated inflammation is the major reason for the relapses, we control the inflammation. So most of these drugs are in the class of immunomodulators. So by modulating and attacking various mechanisms through which the immune mediated inflammation happens is the target of these disease modifying therapies, and thus they control the central nervous system inflammation, and then they are able to prevent further clinical as well as radiological. That means no further clinical symptoms and no further MRI activity, what we call as NEDA, that is no evidence of disease activity. Now this concept of NEDA is something which is the ideal case scenario. That means there is no relapses clinically, there is no MRI activity, there is no progression of disease independent of the relapse activity, and now another component to it has been added, that is the NEDA 4, that is the atrophy of the brain. Because when I talked about symptoms of multiple sclerosis, I did mention that at the early stages also there is some involvement of cognition. Now this is a very latest concept. Earlier it was thought that the MS being a disease which is predominantly affecting only the myelin should not affect something which we call as cognition, or so this was predominantly, I would say, highly dependent on the ambulation only. But the concept has changed. The cognition is also an important, and brain atrophy, spinal cord atrophy leading to the ambulation also, and it's more important in the progressive phase, but it is present from the outset. So we have to, though it is difficult to measure through standard procedures in the routine clinical practice, but this is something which should always be looked at and least sought clinically. The last component is now being studied in research. That is, I'm just adding it to complete the topic, that there are certain biomarkers which are being studied as markers of progression and disease activity, both in serum and CSF. So they are also now considered as the part of the what we call as the NEDA 5. So the basic purpose of utilizing or using disease modifying therapy is to achieve NEDA, but unfortunately we don't have any disease modifying therapy as of now which 100% achieve this NEDA. But nevertheless, we have a number of good medications which can be used as disease modifying therapies. There's a huge basket, and today I will stop at this point, saying that if someone asks that who out of the whole cohort of multiple sclerosis, people with multiple sclerosis require disease modifying therapy, I would say, as per the current guidelines by the American Academy, the European Academy and the ACTRIMS, as well as Indian Academy of Neurology, all people with MS who are diagnosed should be offered disease modifying therapies, because this is an approach where we can modify the course of illness. And another concept why I am recommending the use of disease modifying therapy in all people with MS from the outset, even when the disease seems to be mild from outside, is that there is a narrow window of opportunity to control that inflammation. And another concept which is very important, that when we see clinical relapses from outside, for every clinical relapse there are around 10 new lesions which crop up in the MRI. So there is definitely a smoldering type of inflammation which goes on. So maybe this thing which is looking silent from outside, on surveillance MRIs, it shows sometimes activity, and maybe if it is not even showing activity on MRIs, on obviously only in the research settings, it has been definitely shown that the inflammation is still on, and it is never silent if not treated optimally. So all people with MS, they should be offered, and they should be on some or the other disease modifying therapies. Tomorrow we will discuss what are those factors, how do we decide which disease modifying therapy to be chosen, and what are the various ways, what are the various approaches to treat. Now I would end here. Why? Because this is something which you need to assimilate. You suspect based upon the symptoms, you diagnose using few investigations, and by excluding, most importantly, other MS mimics, then you stratify the disease through various measures. There are various tools which are available, standard tools available to the neurologist and the MS physicians. And not only you should not stop at treating the acute attack, but you should also discuss. So the last thing which I want to say in this talk is that this is a shared decision. It's not something this is just prescribed. We put forth the basket of available disease modifying therapy and the appropriate disease modifying therapy in front of the person with MS and obviously the caregivers, because not only the drug factors are to be considered, the most important is the disease factor, and the other factors like finances and everything have to be, because these treatments, they have to continue for long. These are preventive medications to prevent the relapses, prevent the MRI activity, and to prevent the progression independent of relapse activity. So goodbye for now, and have a nice day, have a nice Saturday. I continue with my HDR 100-day walk run challenge, and stay healthy. And remember, my health, my responsibility, from Indian Academy of Neurology. Goodbye.